I'm Dr. Ravi. I am pleased to invite everyone for today's session on advanced thyroid malignancy differentiated thyroid cancer. Before we proceed for the case presentation, we have a pre-session invited talk on the topic the role of radioactive iodine in post-surgery status of differentiated thyroid cancer. For this talk, I would like to invite Dr. Varun Shukla. He is the assistant professor and officer in charge Department of Nuclear Medicine at Mahamana Pandit Madan Mohan Malviya Cancer Center, Varanasi. He will be making the presenting on this topic. Dr. Varun, are you here?
Yes, I'm here.
Hi. I think we can start now. It's already 5:35. Mostly people have already started to join in. I think we can go on with the presentation now.
All right.
Thank you.
Good evening, everybody. So today we'll be discussing the role of nuclear medicine in post-thyroidectomy setting. So,
Dr. Varun, voice is not very clear.
Yeah, is it better right now?
Okay. I guess I do. Can you get your mic a little bit closer?
Yeah. Is it better right now?
I think we can proceed.
Okay, take care. So today we'll be discussing the role of nuclear medicine and management of differentiated thyroid cancers post-thyroidectomy. So when it comes to nuclear medicine and thyroid cancers, our mainstay of management is radioactive iodine. If we are giving radioactive iodine with therapeutic intent, what is the goal of the treatment? So we divide our goal into three categories. That is, first, we can give it for remnant ablation, we can give it as an adjuvant therapy, or we can give it for treatment of metastatic disease. Remnant tissue is just normal thyroid tissue or some microscopic disease left in the thyroid bed. And the need for remnant ablation, one, we can have serum Tg as a more reliable tumor marker if we have ablated the remnant thyroid tissue. There is also increased sensitivity of the RAI imaging to detect local or distant metastasis, and there is decreased risk of local recurrence or distant mets. Success of remnant ablation depends on the amount of remnant thyroid tissue. If the tissue left behind is significant, then it would need revision surgery. When a patient comes to us post-thyroidectomy, what are the things we look for? So first, we'll go through the detailed HPR report. We'll see if there was any pre-op imaging, for example, CT thorax to evaluate for lung nodules. We'll see the present T3, T4, TSH because we want the TSH to be adequately raised. We'll look for TG and anti-TG, preferably stimulated. We will use USG neg to evaluate for thyroid bed and cervical nodes. We can utilize diagnostic RAI to help in clinical decision making and serum calcium for parathyroid status. So what is the role of serum TG? It is usually used as a prognostic marker and helps us in treatment decision making. After surgery, it should go to its lowest point in 3 to 4 weeks. After total thyroidectomy, if the TG is more than 1 to 2, there is increased risk of recurrent or persistent disease in these patients. More than 10 TG indicates likelihood of identifying some RAI-avid metastatic lesions, and more than 30 are associated with poorer survival and need additional investigations and therapy, including RAI therapy. If we add NEC USG along with serum TG, it is known to increase the sensitivity and negative predictive value. There have been studies which say that in low-risk patients, the negative predictive value of a radioiodine scan is increased, and there is also in intermediate and high-risk patients decreased risk of recurrence if the patient has a negative NEC USG. If we use RAI imaging for diagnostic intent, here we want to evaluate the remnant thyroid tissue status or some residual disease or the status of loco-regional or metastatic. The dose given for diagnostic imaging is between 1 to 3 millicurie, and this is done to avoid stunning. The results of these imaging may help us alter the decision to treat or not to treat, and also help us decide the dose of RAI to be administered. Coming to stunning, stunning occurs because radioactive iodine, that is I-131, emits beta radiation, and the thyroid cells and the thyroid cancer cells express NIS. Because of this beta radiation, the NIS is affected, the expression is affected, and it is not able to take up any further administration of radioactive iodine. So after giving a higher dose of diagnostic imaging, for example, if we give 3 to 5 millicuries, now if you send the patient for therapy, the cells might not take up your therapeutic RAI and the patient will have treatment failure. Here comes the utility of using I-123 as an imaging agent. One, it has no beta radiation, so there is no chances of stunning. Second, the imaging quality is better. in our center, we have planned to acquire a cyclotron, and our cyclotron, when it comes, will be the first in India to be able to synthesize I-123. So post-op, when the patient comes, how do we decide for radioactive iodine treatment? So first, we'll stratify the patient according to ATA risk groups, which everybody knows, ATA low, intermediate, and high risk. In the low risk group, actually, there is a lot of conflicting data. And the recent trial, estimable 2, also says that there is no role of RAI, especially in low risk DTC less than 2 centimeter size lesion. But even the low risk patient, if they come to us, we see on case to case basis, we evaluate for serum TG, we see the remnant status, we go through the HPR, and then we decide for treatment. Intermediate risk patients, they can be considered to avoid the risk of recurrent disease. But it is recommended that the patient should undergo RAI therapy in high-risk patients. What is the dose administered? So there is no hard and fast rule to what dose to give to every patient. But if you are giving with intent of remnant ablation, then we give just 30 millicurie to the patient. There have been studies, and giving anything more than 30 millicuries did not have any better response. For intermediate risk patients, between 100 to 150 millicurie is given to these cases. If the patient is of ATA high risk group, usually give more than 150 millicurie, and classically a rule, not a textbook rule, but it is being followed throughout in practice, that if the patient has nodes, we usually give 150 millicurie. If the patient has lung nodule, we give 200 millicurie, and for skeletal mets, we give 250 millicurie as our therapeutic dose. So what are the adverse effects of radioactive iodine therapy? Some nausea and gastric discomfort. Then usually we see that the next day of therapy, the patient have some tenderness and discomfort in the salivary glands because of sialaminitis. If a patient undergoes multiple cycles of radioactive iodine therapy, the patient can have xerostomia. There is also chances of bone marrow suppression. Therefore, we monitor patients with ANC and platelet counts. If a patient is undergoing multiple cycles of RAI, then there are chances of developing some secondary malignancies. Most common being hematological malignancies. Study says that there is 1% chance of patient getting hematological malignancies, most common being leukemias. How do we suppress TSH post-RAI? So it is dependent on the ATA risk group. In low risk, there is no such suppression. We just keep the TSH goal between 0.5 to 2. In intermediate, we have mild suppression between 0.1 to 0.5. And for high risk patients, it is moderate to high suppression, that is less than 0.1. Now, after our RAI, we call the patient at 6 months. This is our first follow-up. At the 6-month mark, we evaluate the patient with preferably stimulated serum TG, USG neck, and if desired, a whole body RAI scan. Using the result of these tests, the patient undergoes dynamic risk stratification, which means that if a patient is of intermediate risk, high risk, they might not stay in this risk group throughout their life or throughout their clinical follow-up. This dynamic risk stratification actually categorizes the response to treatment in these 4 categories. First is excellent response, then biochemical incomplete response, then structural incomplete response, and then indeterminate response. Excellent response are the cases where the stimulated TG is less than 1 and the patient has normal RAI image. Biochemical incomplete responses when the stimulated TG is more than 10, but we do not see any structural disease, that is normal RAI imaging. Structural incomplete response explains itself. There is evidence of structural disease regardless of TG levels. And any non-specific or inconclusive findings are indeterminate response. So how do we manage it further? So the excellent response patients undergo TSH suppression just like ATA low risk between 0.5 to 2, and then we can follow them up every year, every 12 months. For biochemical incomplete response, if we see raised TG, we can ask them to repeat TG in 3 months. If the TG is still high or rising, then the patient can undergo further investigation to find the cause of rise in TG. The TSH suppression in biochemical incomplete group is similar to ATA intermediate, that is between 0.1 to 0.5. For structural incomplete, you have already identified the structural disease, so you should treat it. So if it's feasible to surgery, we'll do surgery. If RT is better, we'll do RT or RAI if the patient has multiple mets. TSH suppression here is like ATA high risk, that is less than 0.1. Indeterminate cases, the TSH suppression goal is between 0.1 to 0.5. But when we are doing long-term TSH suppression, there are some adverse effects. For example, subclinical thyrotoxicosis, there is increased risk of atrial fibrillation. In perimenopausal women, there is increased risk of osteoporosis. in patients with non-ischemic heart disease, there is chances of exacerbation of angina. So ATA gives a chart in which there are risk groups, and then there are your dynamic risk stratification groups. And with the help of this chart, you can decide what TSH suppression goal the patient should have. Now, Dr. Mani will discuss administration of radioactive iodine and some challenging scenarios which we face in our clinical evaluation.
Good evening, everyone. Moving on to the administration aspect of iodine 131, the preparation which we need before RAI. We need the patient to stay off Eltroxin. If the patient is on T4, we need at least 4 weeks of withdrawal. If the patient is on T3, we need minimum 2 weeks of withdrawal. In those patients who cannot tolerate thyroid withdrawal, or in those patients who are having psychiatric comorbidities, we use recombinant TSH at a dosage of 0.9 milligrams subcutaneous injection on 2 consecutive days, followed by radioactive iodine administration on the 3rd day and the whole body imaging on the 5th day. Coming to iodine restriction, we need at least 2 weeks of iodine restriction before RAA. We advise the patient to stay off seafoods and iodine-containing drugs like amiodarone, multiple multivitamin drugs, and topical ointments like povidone iodine. And we also advise the patient to stay off iodized table salt, and we ask them to use the crystal salt, that too in a minimized amount. Coming to the IV contrast, we advise, or we usually administer radioactive iodine 4 weeks after the preceding any contrast enhanced imaging like CECT. And the baseline workup includes your complete blood count, LFT and RFT. And in case of female patients, it is mandatory to rule out pregnancy with a negative urine pregnancy test at least within 72 hours before RA administration. And the TSH target at the time of therapy, we need at least 30 at the time of administration to mount adequate response to the radioactive iodine. And those patients who require a dose more than 30 millicurie needs to be admitted in a specialized radionuclide therapy isolation ward. And the pre-medications which we use before radioactive iodine, it includes our PPI to manage the gastritis induced by this radioactive iodine. And we use laxatives because we need early bowel clearance of the radioactive iodine which crosses the stomach to the bowel. In patients who are having brain mets or spinal metastasis with impending cord compression, we used to have a steroid cover to tackle the inflammation which occurs after the radioactive iodine administration. Coming to the discharge aspect, after isolation for a quiet period of time, we discharge the patient when the radiation level is reduced to the acceptable limits, that is less than 5 mR per hour at a distance of 1 meter according to the Atomic Energy Regulatory Board regulation. Coming to the radiation safety aspects, this iodine 131 is very highly volatile. So we keep it in a negative pressure fume hood, and it should be handled in a very careful way. And at the same time, patients are also counseled to follow strict radiation safety precautions, both during the inpatient time and also after the discharge. After the discharge, we ask the patient preferably to stay in a separate room and to use a separate washroom, and to keep their clothes separately and wash them separately, to have food in a separate utensil, and to stay off any pregnant women or children, or at least to maintain a distance of 6 feet. Then we come to the challenging aspects which we face during the radioactive iodine treatment. First one is RA refractory DTC. There are 4 scenarios in this RA refractory DTC. The first one being the malignant metastatic tissue does not ever concentrate RA. There is no uptake outside the thyroid bed at the first post-therapeutic whole body scan. The second scenario, where the tumor tissue loses the ability to concentrate radioactive iodine after previous evidence of RA disease in the absence of stable iodine contamination. And the third scenario, the radioactive iodine is concentrated in some lesions, but it is not concentrated in few other metastatic lesions. And the fourth one is where the metastatic disease progresses despite significant concentration of radioactive iodine. Coming to the management of RA refractory DTC, we determine the extent of metastatic disease by staging imaging studies, and we assess the degree of potential symptoms from those disease types, and we understand the comorbidities that might influence the choice of therapies, and we determine the rate of progression of these radiographically evident lesions. Mostly, these are lesion-oriented and symptomatic treatments, which include stereotactic radiation, thermal ablation, TKA, and bone-directed healing. And the next challenging thing we face is TENS, that is thyroglobulin elevated negative iodine scintigraphy. This we encounter in around 2 to 13% of cases. The first thing to rule out before terming it as TENS is iodine interference, where the dietary iodine may interfere with the iodine taking up capacity of the residual thyroid tissue. And sometimes we may get false positive TENS due to the inferior imaging quality of I-131 over I-123. And the tissue might de-differentiate and might lose the ability to concentrate radioactive iodine. Evaluation of TENS includes ultrasound neck. We look for any disease which can be targeted with some kind of therapies. If it is located, whether we look for the operability of the tissue, and if the disease is inoperable, then we look for like empirical RA, EBRT, TKI, PRRT, redifferentiation therapy, and chemotherapy. If the lesion is not located with ultrasound, then we'll go ahead with FDG PET-CT. If the lesion is located, then same, the patient will be advised for a surgical opinion for the operability. And if the disease is not located even with FDG PET-CT, then we advise observation with TSH suppression. And coming to the role of empirical RA, the empirical RA has plays a major role in two aspects. One for disease localization, because when we do a diagnostic imaging with a lower amount of radioactive iodine, sometimes some smaller lesions may not be evident in the scan. But after giving this empirical RA, which is a higher dose, some smaller lesions can become evident. And this is also for the non-surgical candidates. This empirical RA is given. Usually, it is usually in the patients with serum TG more than 10, and the dose range is 100 to 200 milligram dose. If the post-therapy imaging is also negative, then there is no further role of RA in these patients. If post-therapy thyroglobulin shows a decreasing trend, there is better survival in those patients. Thus, this is the role of nuclear medicine in the management of TENS, and we have briefly covered the role of nuclear medicine in DTC in the post-operative period. Thank you.
Thank you, Dr. Varun and Dr. Mani, for this informative talk. I think most of us are being benefited by this talk, and we got to know more about post-surgery, post-RAI treatments and their protocols. Moving on to our next session, we have today the topic Advanced Thyroid Malignancies, which will be presented by Dr. Krishna Prasad from Kidwai Memorial Institute of Oncology, Bangalore. We have our moderators for the day, Dr. Samit Chopra sir. He is Chief Department of Head and Neck Oncology, Patel Hospital, Jalandhar. We have Dr. K. Sidappa. He is Associate Professor, Department of Head and Neck Surgery, Kidwai Memorial Hospital, Bangalore. Sir, are you available? Dr. Kanika Rana ma'am. She is Associate Consultant in Head and Neck Oncology, Vedanta Hospital, Gurgaon. And Dr. Smriti Panda ma'am. She is Assistant Professor, Department of Otorhinolaryngology, AIMS, Delhi. Are the moderators there? Sidappa sir? Smriti,
Hi Ravi, I'm here.
Also, I would like to request Dr. Varun Shukla sir to be there as a moderator for the session. I would request Dr. Krishna Prasad to switch on his, he can share his screen with us. Dr. Krishna, are you available?
Hello, am I audible?
Yeah, you're audible, Dr. Krishna.
Yeah, good.
Hello, good evening. I'm Dr. Sapir. KP.
Yeah.
Hold on. Regarding iodine-130 with brain mets, most of the time, hello, can you hear me?
Hello.
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 We can hear you, Krishna Prasad. Please go ahead.
Yeah.
Okay.
Able to see my screen?
Yes, we can.
Yeah. Good evening, everyone. Today, my topic is advanced thyroid malignancy.
Dr. Krishna, sorry to interrupt. Can you put it on slide share? Full screen. The next one.
Which one?
The next to it. The next to your Zoom. You can start your slideshow directly. No, it would be the next to it. The next to it on the right hand side. Yeah. The next. Yeah. Okay.
My patient is Shekharappa. So 57-year-old male patient, farmer by occupation, resident of Bellary district, presented with a chief complaint of swelling in front of the neck for 10 years, change in voice for 3 months, pain in the right eye for 3 months, unable to shrug the right shoulder for 3 months, and deviation of tongue to the right side for 3 months. Coming to the history of present illness, patient was apparently normal 10 years back. Then he noticed a small swelling of 2 into 2 centimeters in size in front of the neck, which remained constant for 8 years and gradually started increasing for last 2 years. There is no history of sudden increase in size or no history of pain associated with the swelling. Patient insidiously noticed a change in voice 3 months back, which is hoarse in nature. There is no history of difficulty in breathing or swallowing, no history of excessive sweating, heat intolerance, palpitations, diarrhea, weight loss, history of hyperthyroidism, or no history of cold intolerance, constipation, lethargy, weight gain, no history of cough, hemoptysis, bone pain. Patient had a history of deep-seated pain in the right eye for 3 months, which was continuous, and there is no aggravating and relieving factors, no history of change in vision or double vision. Patient was unable to shrug the right shoulder for 3 months and deviation of tongue to the right side for 3 months. So patient had a history of hard of hearing on the right side from the last 3 months. There is no history of loss of smell and altered sensation on the face, a deviation of angle of mouth, difficulty in eye closure, and nasal regurgitation. There is no history of headache, vomitings, altered sensorium, seizures, or weakness of neck. So past history, patient had history of neck swelling on the left side 20 years back, for which he got operated, left hemithyroidectomy done, and the post-operative period was uneventful. There is no history of hypertension, diabetes, tuberculosis, bronchial asthma, epilepsy, allergy. There is no allergy history and drug history. Personal history, he takes mixed diet and uses non-iodinated salt. That's raw salt for cooking. Bowel and bladder habits were normal and sleep pattern undisturbed. There is no history of loss of appetite and weight, no history of alcohol, tobacco intake. Family history, no history of thyroid and other related malignancies. General examination, patient was, that is the history in brief. So 57-year-old male patient, farmer by occupation, presented with a chief complaint of swelling in front of the neck for past 10 years. And recent onset change in, for the last 3 months, change in voice, and difficult to shrug the shoulder and deviation of tongue to the right side.
Okay, Ravi, did you want us to interject at this time?
So most probably I'm dealing with the thyroid.
Sure.
So you can interject as and when,
So
whenever you
we wanted to know the structure with which you do the Mahamana case discussions. Great initiative, by the way. And Krishna Prasad, good luck. I will ask on behalf of the moderators about your training background and your seniority level so that we can guide the questions accordingly.
Yes.
Yeah, so please tell us, are you a resident currently at Kedwai?
Sorry, sir. I'm a resident, exam going resident, sir. Final year MCH resident.
Okay. Great. I'll point out something very basic to start off with, Krishna Prasad.
Yes.
You used a patient identifier in the first slide. And normally, I would advise you to use patient initials or use something which is not able to isolate or identify the patient to the degree that you have. That being said, moving on to the history, thanks for encapsulating the history at the end. I think it's very important to give us a 3-line summarization of your history, which you did.
Yes.
You already started telling us what you expect or anticipate in this patient as a thyroid malignancy. But can I ask you a question? Based on the history, what cranial nerves do you anticipate will be involved in this patient?
Sir, lower cranial nerves.
Okay. Is there any unusual anticipated pattern of involvement of the cranial nerves that you are thinking of based on the patient's history? I find something very unusual in the pattern of cranial nerve deficits. Can you just point it out only based on the history?
One is involvement of the 8th hard of hearing, sir.
Yeah, very nice. So the fact that the 8th nerve is involved and the 7th is not involved because the patient does not have any history of deviation is something which goes against the natural course of progression. So that's something that you might want to consider as an incidental thing, or maybe a premature presbycusis or something like that.
Yes,
or a hearing loss which is definable by any other etiology. That's it. If the moderators have any other questions before we move on to the examination, please.
Krishna, did you ask for the radiation exposure history?
Yes, madam. Patient doesn't have any history of radiation exposure.
And what are the malignancies, or what are the instances where you can have history of radiation exposure? Like
so actually, previously there you were asking etiology, madam, or effects.
So what do you specifically ask when you want to ask for radiation exposure?
Yeah, thyroid malignancies risk of increases with radiation exposure. So we have to ask. And previously they used to use low dose radiation for benign diseases. So that may be the cause.
Can you name
Also,
some?
you need to know about the occupation and in current scenarios, where do patients receive radiation as a part of treatment in today's era?
Today's era, we are not using low dose radiation, madam, but patient, if he had any lymphomas or anything, he might have received. So previously they used to give for acne and chronic dermatitis, seborrheic dermatitis for those things.
Couple of other indications, Krishna. Based on what our co-moderator was asking you, you'd typically be looking at other indications like tonsillitis. It used to be done in the past. Also, one potential current day indication is keloid, even though the radiation fields would typically not cover that.
Even fungal infection they used to give, tuberculosis they used to give in older days.
I think Dr. Siddhapa's voice is probably not that clear.
Oh, are you able to hear me now?
It's echoing. It's high pitched. I don't think, at least I'm not able to hear it. Maybe Ravi can tell us if he's able to hear better.
You asked the fastest history of thyroidectomy. Did you get any details? What
Dr. Siddhapa, your voice is not clear. We are not able to make it.
Okay. Just a minute, hold on. Now are you able to?
Hello? Hello?
So, Ravi, I think we should just proceed.
Yeah, I think we can proceed. Yeah.
Hello?
Yeah, Krishna, please proceed.
Yes, sir. Thank you.
Yeah.
So coming to general examination, patient was examined after taking the informed consent in well-illuminated room. Patient is conscious and coherent with moderately built and moderately nourished with ECOG score 1. Coming to the vitals, pulse rate 84 beats per minute, regular rhythmic and respiratory rate 16 beats per minute, so 16 per minute, and thoracoabdominal blood pressure 130 by 80 mm of mercury in left upper arm sitting position. Cardiovascular system and respiratory system were fine and no added sounds per abdomen. Coming to the local examination on inspection, there is a 5 to 8 centimeter size horizontally oval swelling in front of the neck, which is moving with deglutition. Surface is bosselated. Skin over the swelling is stretched and shiny. Borders are defined and extend. Superiorly, the border is extending up to the upper border, thyroid notch, and inferiorly up to the suprasternal notch and clavicle, and laterally it's going under the middle border of the right SCM, and medially just crossing the midline. There is a 5 centimeter size horizontal surgical scar present in the left skin crease on the left side. There is a 2.5 to 1.5 centimeter hypopigmented patch present in the neck and the midline above the thyroid notch. No other neck swellings, engorged veins, and no visible pulsations noted. Pemberton sign is negative, and trachea appears to be deviated to the left. Coming to palpation, the swelling is non-tender, and inspectory findings regarding size, shape, position are confirmed, and surface is nodular, firm in consistency, able to get below the swelling on swallowing only. Skin over the swelling is pinchable. On SCM contraction, the lateral part of the swelling becomes less prominent. No palpable cervical nodes found. Laryngeal framework and trachea is shifted to the left side, confirmed by 3-finger test. Percussion. On percussion, there is a dull note noted over the upper part of the manubrium, and on auscultation, there is a no bruit over the upper pole of the thyroid gland. So, Hopkins examination, right vocal cord is in paramedian position and non-mobile. Left vocal cord is crossing the midline, compensating with a minimum phonatory gap. Coming to the examination of the cranial nerve, olfactory nerve and optic nerve, oculomotor and trochlear were fine. 6th nerve palsy noted on the right side, and 5th nerve and 7th nerve were normal. Again, 8th nerve ring is negative on the right side and Weber lateralized to the right side. 9th and 10th coming gag reflex decreased on the right side, unable to shrug the shoulder on the right side, especially against the resistance, and tongue deviated to the right side. There is a partial atrophy of the right half of the tongue present. Examination of scalp was normal. Examination of ear, nose, throat. So on DNE, there is a submucosal bulge noted in the nasopharynx. Examination of the oral cavity and oropharynx, uvula deviated to the left side. So that is about my examination. Shall I give differential diagnosis?
So, the orbital examination.
Sorry, sir.
Did you mention that? I might have missed it.
General examination.
Yeah. So, orbital examination, because you noted an
yes, sir. Sir, sorry, actually, I didn't write it.
I think it's, and that becomes relevant.
Yes, sir.
Yeah,
on general examination, I thought of mentioning, I forgot.
Yeah.
So,
examination reported with eye swelling, which now appears will be due to something else because of the nasopharyngeal bulge that you pointed out. But when you note something in the history, it becomes relevant to note it as a negative examination point in the examination specifically.
Yes, sir. So examination of eyes, both visual acuity is fine, and both eye movements, abduction is limited in the right eye, sir.
That you mentioned, yes.
Yes, no signs of hyperthyroidism.
So, contrary to the eye swelling that the patient was pointing out, you did not note any eye swelling or any eye bulge or any eye mass on examination, correct?
No eye swelling, sir. It is actually deep-seated eye pain, sir.
Sure, that's fine. That's fine.
Dr. Krishna, this is Dr. Smriti here.
Hi, madam. Please.
So can you tell us what is the possible reason for all these cranial nerves involvement?
But actually, it could be, sir, there is an intracranial or a skull-base lesion, so which is involving these cranial nerves. It may be or may not be related to the thyroid malignancy.
What was the previous histology? The patient has already undergone a hemithyroidectomy. So what was the histology at that time?
But actually, histology reports are not there, madam, because it was operated very long back, 25 years back. But the only thing is, from the history, we came on examination. We came to know that it is a thyroid operated. So,
since you're suspecting a skull base lesion along with the thyroid mass, so yes. What do you think is the possible histology?
Possible histology is anaplastic, follicular neoplasm, follicular cancer.
Yes, follicular CA is known to cause skeletal metastasis.
Yes.
And one more question I wanted to ask: can you let us know what are the signs of mediastinal, retrosternal extension of goiter during the clinical examination?
Yes, ma'am. Actually, in this case, the lower border is not able to make out on inspection. So, but on palpation, we could able to get below the swelling. During deglutition, it is moving up. So otherwise, small retrosternal component is there, madam. So if significant component is there, we will see the engorged veins on the neck, and patient will have difficulty in breathing, other and positive Pemberton's, and also we may get.
And you have also mentioned about auscultation, percussion over the manub. Yeah.
Yes, it is like plunging type matter. It is coming out during swallowing. Otherwise, it is going in.
We can move to your differential diagnosis, Krishna.
Yes.
While you're doing that, Ravi, what's the anticipated time for presentation and what's the anticipated time for discussion in your case discussion series now?
The total time is till around 7:15 p.m. So I think we have around 40-45 minutes in hand.
Sure. So my differential diagnosis is 57-year-old patient presented with a swelling in the swelling in front of the neck for 10 years and lower cranial nerve palsy symptoms and deep-seated eye pain. On examination, found to have a thyroid multinodular goiter on the right lobe of the thyroid with lower cranial nerve palsy. So most probably thyroid carcinoma with a thyroid carcinoma with intracranial or skull-base metastasis, or so there could be two different pathologies. One will be the thyroid carcinoma because of recent increase in size with the cranial nerve palsies may be secondary to intracranial neoplasms unrelated to the thyroid, or it can be the old stroke. So these three differential diagnoses I am thinking, sir.
Can you go to the relevant slide? Can you explain the mechanism by which the deep-seated eye pain would have resulted as a direct involvement of the neural involvement of the skull base lesion? And this is without looking at radiology. Can you just give us the usual pathway?
Deep-seated eye pain, sir. Yes. Sir, orbital apex, the tumor involving the orbital apex or cavernous sinus involvement. Sir.
Why do you anticipate cranial nerve 6 to be involved more than other nerves in the orbital apex, including superior orbital fissure, including 3-4?
Yes, sir. 3-4 and 5, these nerves usually will travel on the lateral wall of the cavernous sinus, whereas abducens and internal carotid artery travel through the cavernous sinus. Sir. So most often abducens is involved when cavernous sinus is involved.
And a longer course through the skull base as well, right? Cranial nerve 4 has a very short course.
Yes, sir. Very long course, abducens. Longest.
Okay, let's move forward. How do you want to elucidate your diagnosis? Yes, of course.
Hello?
Yeah.
Hello, sir. Hello.
Hello, KP.
Sir.
Past history of thyroidectomy 20 years. Now the patient have other lobe there is a multinodular goiter, some cranial nerve palsy.
Yes, sir.
So what inference you get from your thyroidectomy and now again other lobes enlarged, you suspect skull-based meds. Does patient have intracranial tension on the
Sir, actually, sir, the latency period is very long. So probably that earlier he was operated for maybe the benign etiology. So because 10 to 20 years, that is 25 years back.
Yeah.
So the patient started having multinodular goiter. So 10 years back, we know that long-standing multinodular goiters converts into follicular neoplasms over a period of time. That may be
even though, it can be like that. Otherwise, previously it was the thyroid C and thyroid only, but it's low risk. That's why epithyroidectomy histology you don't know. That's because the natural history of the disease, thyroid. This is how we debate becomes epithyroidectomy or total thyroidectomy, the component.
Yes, sir.
Yeah.
Your answer was partially correct to Dr. Siddharpa's question, Krishna. I would also add, in addition to what you already said, Krishna, that
yes, sir.
That we typically, a thyroid is an organ where differentiated foci coexist with benign pathology. And like he pointed out, and like Dr. Smriti asked you, since we don't have a histopathology confirmation from the remote thyroidectomy that this patient had, there is a possibility that the patient might have had a follicular neoplasm at that time. Over a course of 2.5 decades, the lesion not only became de-differentiated, but also more aggressive. And also, we know that thyroid neoplasms are multifocal. Virtually always, whenever you do serial step sectioning of examinations, this disease is in very a small proportion of instances unifocal. Usually it's multifocal. So you have to consider that there was a thyroid neoplasm existing at that time itself. We are limited by our lack of histopathology from that surgery, which is why this is probably you can't conclude. So at the end, your diagnosis will remain a range of differential diagnosis only.
So Dr. Krishna, why do you say follicular and not papillary? Papillary can also have distant metastasis, right?
Yes, madam.
So what is the more...
yes, madam. Usually follicular CS usually are angioinvasive, madam. They spread, they mostly have metastasis through the, metastasis into the bones, especially the axial system. Like
that was Dr. Kanika, right?
Whereas the papillary carcinomas usually have metastasis to lung and lung bones and liver.
So, and papillaries have more lymph node metastasis. And in your examination, you've categorized no cervical lymph node.
So there is a possibility. Was that Dr. Kanika who asked the question?
Yes, sir.
Yeah. Hi, Kanika. How are you? So,
hi, sir.
Yeah. So the possibility of a lymph node eroding or reaching or abutting the skull base and causing multiple cranial nerve deficits also needs to be considered. So when you say follicular carcinoma, I would echo Dr. Kanika's view and tell you that there is a possibility of papillary. Of course, we are at that point of the case discussion where differentiated thyroid cancer as a whole needs to be considered. And as we move on, just like any other long case presentation, you will hone in on your final diagnosis based on that. But yes, it could be papillary, a lymph node met, which could be abutting or eroding the skull.
Yes, sir, you are right. Even up to 20% of the papillary carcinoma also can spread by metagenically to bones. Not only main higher incidence for lymph nodes and lungs, but the retropharyngeal is the cranial.
So before we move on, did you want to answer Dr. Ravi's question in the chat box about whether you can isolate your differential diagnosis based on a serum thyroglobulin? Be careful when you answer this question because it's a question that's frequently asked, and you know that there are caveats as well as benefits of this approach. Now, please.
To narrow the differential diagnosis based on thyroglobulin levels, sir.
Yeah, that's the question that's typed in the chat box.
So no, sir, actually, because I cannot confirm the metastasis only based on thyroglobulin levels. So thyroglobulin can be elevated, but it may not be the cause for intracranial or skull.
Yeah, that's the correct answer. That being said, ATA guidelines and multiple other guidelines tell you that a routine estimation of thyroglobulin should not be used in the routine evaluation.
Because here radioactive iodine also not given, sir. So only sensitivity of the thyroglobulin also won't be there.
No, but can you give us a specific clinical scenario in which thyroglobulin would be beneficial, estimation of serum thyroglobulin would be beneficial in this setting at the point of diagnosis? We're not talking about post-treatment. We're not talking about follow-up. Any clinical scenario in which you think thyroglobulin would be helpful?
So post-op or pre-op, sir?
Pre-op. So again, let me repeat the question. ATA and other organizations recommend that routine use of thyroglobulin, or let me finish the question. Routine use of thyroglobulin in the routine, remember, routine evaluation of a thyroid nodule is not recommended. Are there any specific clinical scenarios where you would recommend ordering a thyroglobulin level in patients for initial workup of a thyroid nodule?
Sir, actually, I have gone through one paper. So in that, what they mentioned is thyroglobulin may not be elevated in 10 to 15% of the patients, differentiated thyroid malignancies. They are the non-secretors. So that those patients can be identified, and those patients are not useful for follow-up with thyroglobulin.
No, but
that again, is the only advantage of doing pre.
So
as per guidelines, it is not this.
I'll answer a couple of scenarios because, like routine evaluation is not recommended. Let's say you have an isolated intracranial lesion, cerebral parenchymal lesion, with a nodule that looks moderately suspicious, but the FNA is inconclusive. All right. In that case, where the potential metastatic lesion is not amenable to pathological sampling, barring doing a big procedure or a stereotactic biopsy, typically you would order a thyroglobulin. Why? Because it's relatively non-invasive. It's a simple blood test, readily available. And in that case, you can move forward with a total thyroidectomy. This does not apply to our specific case. But there are very specific clinical scenarios which are not guideline-based in which you would recommend ordering a thyroglobulin. Now, you are correct. 10 to 15% chance that even the second patient that I just mentioned would be a non-secretor. But there's no harm in getting it done, right? If it is in the hundreds and the thousands, you know that you're dealing with metastatic thyroid cancer, therein you do the appropriate thyroidectomy accordingly. Okay, does that make sense? Please go ahead.
Yes.
So, Dr. Krishna, how would you proceed now? What will be your next step in investigations?
Yes, madam. The first investigation, I would like to go for serum T3, T4, TSH levels, thyroid profile. Next, I will go for ultrasound guided FNAC, madam. Here, the ultrasound I am preferring only for taking needle biopsy. So, because anyway, this patient needs other modes of imaging. So, first, for confirmation of the diagnosis, thyroid lesion, I will go for ultrasound guided FNAC.
You have such a big node. Do you want an ultrasound guided FNAC?
Sir, it
patient
is
use thyroid.
Yes, sir. It is there's a multinodular goiter, sir. So by using ultrasound, I can characterize the nodule from where I want to take the put a needle.
Okay. And what are the other indications in a normal patient, not for this specific patient, where you would prefer ultrasound guided FNAC over a normal FNAC? Can you just enumerate where do you want an ultrasound guided FNAC?
The nodules which are placed posteriorly and the overlapping nodule where and ultrasound guided FNACs, other indications are nodes, central nodes or very small nodes.
No, for thyroid. Let's talk about thyroid only.
Madam. So previous FNA, if it comes, that is if previous FNA comes as an indeterminate nodule, then the repeated one I will go for ultrasound guided FNA.
Okay, and more? Anything else? You said posterior, which is fine, and especially you would like to do it if you can't palpate it, deep-seated, something that you have checked incidentally on radiology, and the nodule is deep, so deep that you can't palpate it. So that should be the first indication. Also in solid cystic, where you want your needle to hit the solid part of the nodule and not the cystic part.
Yes.
So if you have mixed nodules, then also you do solid USG guided FNAC.
Yes.
Posteriorly located and also classically described in bulky neck, fat neck, short necks, where your accuracy of a normal palpatory FNAC will be lesser than an ultrasound guide.
KP. An ultrasound is 7 mm classical thyroid 5 nodules is there, deep seated. Do you recommend FNAC for that?
Thyroid, sir?
Thyroid. 7 mm nodule, all classical features of thyroids. 5. Do you recommend FNAC?
Sir, actually, as per ATN, we need to do the FNAC, and we can keep on
that's
regular
what
follow-up.
Madam was asking. Thyroids, depending on the thyroid scoring, and I think you can do this depending on the size of the lesion. Your recommendation FNAC to be done or not, you should say. Okay.
Yes. So I have a comment about the first one and a question for you about the second one, Krishna Prasad. regarding our co-moderator's point about textbook indications of doing an ultrasound-guided FNA. It's important to know that in a resource-stratified country, where we also need STARADs as much as Bethesda for consolidated decision-making, usually it's better to do every FNA in a guided fashion. That being said, I'll also play the devil's advocate and tell you that because we have the same resource constraints, don't hold off an FNAC just because you don't have ultrasound guidance. Any preferred FNA of a thyroid nodule, because of the vascularity, because of solid versus cystic, which has been pointed out, and because of the ability to do a thyroid staging at the same time, you should prefer all FNAs of the thyroid to be ultrasound guided. Okay.
Yes.
Now, the question in extension to Dr. Siddharpa's point, what paper are you quoting when you are saying that a TIRADS 5 7 millimeter hypoechoic nodule, well, hypoechoic gets included in TIRADS 5 anyway, it's part of the composite scoring.
Yes.
A TIRADS 5 posteriorly located nodule does not need FNA. What paper are you basing that on? Is there any paper which helps you? And again, we are talking about way when the TIRADS was done.
Sir, this one is based on actually, as per ATA guidelines, no need. And there is a Japanese study, sir, that one.
Yeah, so the ACR white paper in 2017, and ACR is American College of Radiology, which actually made us use TIRADs in a more widespread fashion. And again, I doubt if we have a radiologist in the group, but maybe they could add. We know that most of these TIRADS 5 nodules, which are suspicious, solitary, posteriorly located, would typically end up being DTC. So based on that, you can offer treatment or counsel them for an FNA. You can counsel for them in the sake of patient counseling, but in case you have to take a clinical decision, you can take it based on the assumption that the malignancy risk is very high.
Yes, sir. Especially if patient is having a radiation exposure or family history.
Yeah, that's a relative indication. Please go ahead.
Dr. Krishna, apart from ultrasound neck, what other radiology would you advise in this patient?
No, actually, in this case, I will advise CECT contrast enhanced CT scan from the skull base to the thorax, and MRI contrast gadolinium and contrasted MRI with brain, madam.
So what information would these provide apart from whatever information you get on the ultrasound?
No, this is a bulky lesion, so central lymph nodes I cannot make out with ultrasound alone, and especially it is having retrosternal minimal retrosternal extension, so it is always advisable to go with CT scan. Whereas for skull base, so both MRI and CT are complementary. Especially for brain, we need MRI. So MRI brain with CECT from skull base to thorax. Thorax is to rule out lung metastasis.
Yeah, you'd also want to know about the aerodigestive tract involvement, because it's a large goiter. Because you already said there is vocal cord palsy in this patient. So maybe there is a mass lesion going into the tracheoesophageal groove, and there can be some amount of tracheal invasion or compression. Yeah. Okay. Would you advise a PET CT in this case?
Actually, PET CT can be done, but as per guidelines, it is not indicated. It's not superior to MRI and CT, but PET CT can be done. So the one thing is, if PET uptake is there, the radiation ability is less. So prognostication, it may be used.
Actually, if you're suspecting a dedifferentiated variety or a poorly differentiated histology, so in those cases, probably your PET CT would be more informative.
So, based on Ravi's brief, we will have some time for workup because we need at least half an hour to talk about management. Let's quickly run through the tests that had been recommended in the initial talk also for workup of a thyroid nodule. We've talked about cross-sectional radiology, thyroglobulin ultrasound. One basic thing that we have not talked about here is that you want to make sure that the patient is euthyroid, because you don't want to have implications of biochemical or clinically manifest hyperthyroidism. So always get a thyroid function profile done, regardless of however aggressive the tumor is. Yes. The point that Dr. Panda made was very relevant. You might want to, if you're suspecting dedifferentiated or anaplastic etiology, in that case, would you want to do something else prior to your cross-sectional radiology? Do you get more information in poorly or dedifferentiated histology by doing some other pathological sampling?
So, true cut biopsy, sir?
Yes, a core biopsy. If you're suspecting dedifferentiated or undifferentiated histology, you should do a core biopsy. Following that, if it's dedifferentiated and if the final pathology shows features suggestive of anaplastic, as Dr. Panda recommended, you could consider doing an upfront PET CT, and whatever anatomical information you get from that, you can supplement that with, like you said, an MRI of the skull base or an MRI.
Yes.
Okay. Why don't we move forward in your slides to maybe the point where you finish the workup, and moderators can ask questions while we move on. Okay, so we can stop here. We can stop at the radiology. The next one, please. Yes. Do you want to quickly encapsulate what the radiology says?
Sir, actually, thyroid, well-defined heterogeneous enhancing lesion with central necrosis involving the right lobe of the thyroid with teeny foci of calcification. So with minimal retrosternal extension. That's about thyroid, sir. And isthmus and contralateral lobe. Now, actually, they gave left lobe of the thyroid appears normal, but on imaging, it is not there, sir. So I will play the CT scan. Is there. So coming to the skull-base lesion, it is an osteolytic lesion enhancing the soft tissue component. Osteolytic lesion with enhancing soft tissue component involving the clivus, sella, and lesion measuring 4.3 into 4.5 centimeters. Lesion is destroying the petrous apex on the right side. And there is an encasement of the internal carotid artery and in the cavernous sinus with foramina involved, skull-base foramina involvement, jugular foramina and hypoglossal. So that's about this one, sir. And additional small teeny lytic lesion at the C4 vertebra also noted. They gave, they are suspecting CA thyroid with skull-base metastasis as per radiology.
Sure. Go ahead, please.
Sir, can I play the video? This one, sir, imaging?
Sure.
Yes, please.
The retrosternal.
Yeah, we got a good look. I think we can move on because there'll be questions from everyone. So let's move on to the next slide. Your FNA showed follicular neoplasm, correct?
Yes, sir.
Are you suspecting aggressive histology in this patient?
Yes, sir.
Tell us the aggressive variants of differentiated thyroid cancer with no particular focus on papillary versus follicular. You could just enumerate the aggressive variants.
Okay, so in the papillary, tall cell, columnar cell, and diffuse sclerosing variants, sir. In follicular, widely invasive or angioinvasive or widely invasive follicular carcinoma, and Hurthle cell carcinoma. So
have you heard of an entity called insular carcinoma?
Yes, sir. It is a variant of papillary carcinoma in the aggressive variant.
Yeah, follicular.
So let's say you would have done a core biopsy on this patient, and the core biopsy would have been reported as poorly differentiated malignancy.
Yes.
What would have been your differential diagnosis?
So, poorly differentiated malignancy, two things we have to keep in mind. One is anaplastic, poorly differentiated carcinoma, sir.
Yes.
Or
yeah, keep going.
Trabecular, solid, or insular patterns will be there, sir.
So, how do you base it on that? Is there a particular classification which helps you diagnose?
Yes, sir. Turin's criteria is there.
Okay. Can you name the index paper of the Turin proposal?
Turin proposal, diagnostic criteria, sir?
No. Diagnostic criteria are long. There are convolutions, mitosis, and a couple of other criteria that you mentioned.
Yes, sir. Yes, sir.
Yeah. But who was the PI of the Turin proposal?
I don't know, sir.
Volante et al. In 2007. Okay. So we can move on since we have an idea about your radiology. We've talked about core biopsy, PET CT, and thyroid function test now. So I think it completes the complement of investigations. Please move to your next slide.
From my investigations, I narrowed down my differential diagnosis to the follicular carcinoma of the thyroid with intracranial and cervical spleen mets. With TNM staging T4A, N1A, M1 with a stage 4B.
How would you like to proceed, Dr.
From these imaging, the skull-base and intracranial part is actually unresectable. So I will plan for completion hemithyroidectomy right side with a palliative intent, and then I will give the radioactive iodine as well as EBRT for the skull-base lesion. So I will treat this patient with the palliative.
So in your
tests that you would like to do before you proceed with surgery? Since there is a vocal cord palsy, would you like to check something?
Idea.
Any role of bronchoscopy?
Bronchoscopy, esophagoscopy and bronchoscopy. Bronchoscopy is useful, madam, to know whether the invasion is there or not. Whether it is due to vocal cord involvement, whether it is due to recurrent laryngeal nerve involvement or disease invasion.
And how would it change your management? Will it change your management?
Yes, madam, definitely. Because we can't get away with hemithyroidectomy, completion hemithyroidectomy. And locally also we need aggressive treatment based on the Shin grading.
Yes.
CT scan showing already there is no invasion. So do you still consider bronchoscopy?
No, so here the radiology was quite clear, but in case if there is doubt, it is always better to do a bronch, even if you do it before starting your procedure, just to be sure of airway involvement.
Yes.
Absolutely, completely agree. When you order a CT, and sometimes it's challenging if you have ordered a PET CT in the specific clinical scenarios that Dr. Smriti had mentioned.
Yes, sir.
It's challenging to order a 1 millimeter cut, but try to order a 1 millimeter cut through the cervical. Your report was fairly clear that the fat planes of the larynx were well maintained, but I would take and echo Dr. Kanika's step further and say that FOL is absolutely mandatory because you want to rule out aspiration and aspiration in a fixed cord. It's imperative that you're able to tell the patient, and you might be able to solve the problem with something as simple as bolus modification. But you want to make sure that you figure out whether the patient is aspirating to any consistency. It's easier to do that during a fiber optic laryngoscopy because you just have to do 3 food consistencies. For any of those who are not familiar.
Yes, sir.
Yeah. Can you tell me what FEAS is, Krishna Prasad?
Yes, sir.
Yeah. What is FEAS? Please let me.
Functional endoscopic evaluation of swallowing.
So when you have a chance of aspiration, and you want to make sure you rule that out in addition to the tracheoscopy that we talked about. We are assuming you're familiar with the Shin classification, right?
Yes, sir.
Let's move on to locally advanced thyroid cancer, which is the focus of today's talk. What non-contiguous structures of the thyroid typically impact survival, the involvement of which would be there? And this is, I'm only talking about DTC. We're not talking about anaplastic right now.
Yes, sir.
Locally advanced DTC, which Ravi mentioned was the focus of our talk today, of our discussion today. What involvement of what structures impact survival and which ones does not impact survival?
Sir, actually, the esophagus involvement, they found that significant survival difference will be there, sir.
Yes. And what else?
The second is a laryngotracheal, this one. But it is less significant. Recurrent laryngeal involvement doesn't have overall survival difference.
Absolutely. So larynx, recurrent laryngeal nerve, and muscle involvement, by that I mean strap muscle, is shown not to affect survival, but trachea and esophagus, as you mentioned, is known to impact survival.
Especially with esophagus.
Yeah, and that's understandable, right? It's more of a common sense thing. When you know that you don't have any definable boundaries, you have airway involvement. In that case, not only the disease, but the treatment also is more morbid. Okay, so you've already recommended the treatment regimen. What onwards? You've done a completion thyroidectomy. Let's assume, like Dr. Siddhappa mentioned, that there is no intraluminal involvement. So you were, let's say, able to get away with something called a tracheal shave.
Yes.
And you're leaving the skull base met the way it is because it's unresectable. I think all of us would agree with that. Now, subsequent to that, I think you just were in a little bit of a hurry and you immediately said EBRT and palliative. What would you do after? You're done with surgery, you've discharged the patient, what afterwards?
Sir, we should not start thyroxine for this patient. So replace suppressive dose or replacement dose. You should not start. You should. So before that, we have to complete EBRT because it is symptomatic and rapidly progressive. Because cranial nerve involvement is there and vital structures are there. Better to start EBRT rather than waiting for radioiodine everything. And we know that for intracranial lesions, so radioactive iodine is not very effective, but definitely when it is concentrating, we should give.
What's your cutoff beyond which you start checking for iodine avidity?
What's that? Sorry?
What's your cutoff value of TSH? You're allowing the TSH to stimulate, right?
Yes, sir. More than 30.
Okay. And what are the methods for TSH stimulation? I know Dr. Varun pointed that out, but
Yes,
it's an examination.
So just withdrawing the T4 for 4 weeks or withdrawing the T3 for 2 weeks and giving patients who doesn't tolerate prolonged hypothyroidism, psychiatric or other medical comorbidities, then better to give recombinant TSH 0.9 mg 2 consecutive days, and third day we can do radioactive iodine scan or ablation or therapy.
Can you briefly tell me about the safety profile of recombinant TSH for the 2 FDA approved indications? And maybe I'll request Dr. Shukla, if he's still here, to comment on that after Krishna Prasad has tried answering.
Yes, sir. Actually, it is indicated if a medical condition which cannot tolerate hypothyroidism is there, it is indicated in all patients. So otherwise, it is indicated only in beneficial is proven only in low and intermediate risk categories, sir, not in high risk category.
Okay. So
KP, Krishna Prasad. This
Yes,
is
sir.
more of skull post metastasis involving the bearing parenchyma. Actually, it's not extradural component, it's more than the intracranial. And moreover, if I give an option of iodine 131 EBRT, which one you prefer?
Sir, whenever concentrating, radioactive iodine should be given. So in addition to radioactive iodine, EBRT I will consider, sir. Because radioactive iodine alone cannot cure that much disease, such a intracranial component. So I will consider both.
But follicular carcinoma, the iodine 131 uptake will be very good.
Yes, sir. But skull base and intracranial metastasis, the results are not so great with radioactive iodine.
Okay. So EBRT, advantage of EBRT in this case, especially say, and every case is individual. If the intracranial extension is there with cerebral mets, mainly parenchymal, then EBRT will be better than iodine 131. This is mainly a skull base, which is going to intracranially. So EBRT will reduce the what you call cerebral edema, which is caused due to iodine 131 therapy, and allow to appropriate treatment. So your protocol should be like EBRT followed by iodine 131. Both are good for this patient. Yeah.
So let me give you a scenario, Krishna Prasad, that is relevant to your patient.
Yes.
Yeah.
You do the radioactive iodine scan and it does not show any avidity to iodine. Okay.
Yes.
You've gone ahead and done your EBRT.
Yes.
At what point would you consider systemic therapy for this patient?
Sir, if the symptoms are rapidly progressive and expected life expectancy is less than 6 months, then I will consider for starting TKS, systemic therapies.
Can you do a surrogate prediction of survival based on FTG avidity vis-a-vis iodine avidity? I know you mentioned FTG avidity as being a surrogate to non-iodine avidity in like earlier in the presentation.
Yes,
but
sir.
do you have a surrogate for survival to be able to prognosticate these patients?
So exactly the survival rate I don't know, but whenever FDG uptake is there, it is aggressive variant, so survival is poor.
In this case, the location of the metastasis at the skull base actually portends an overall survival which might actually not be as good as other skeletal metastasis, let's say axial or appendicular other metastasis. But compared to other patients, and again, this study has not been done in which skull-based metastasis, which are FDG avid,
Yes,
are going to predict survival. But usually, the ballpark figure is 3 to 4 years is median survival after FDG avidity sets in. What are your options for systemic therapy? We have not talked about the final histopathology. What was the final histopathology in this patient?
Sir, actually, it is a follicular carcinoma, sir. Widely invasive follicular carcinoma.
Okay. So I think there is some relevance in what was being talked about earlier by Dr. Siddhappa, that this was probably a neoplasm to begin with, a follicular neoplasm to begin with. And over time, it has become dedifferentiated, but not to the extent of becoming anaplastic. So it's a widely invasive follicular carcinoma, correct? Widely angioinvasive, we'd imagine.
Yes.
All right. So what are your systemic therapy options?
Sir, I will prefer lenvatinib or sunitinib, sir.
Okay.
Lenvatinib based on the SELECT trial and sunitinib based on the DECISION trial.
Yeah.
And in that they found the survival benefit.
Would you like to do ISC?
Yeah. Did you hear the question, Krishna?
Yeah. Yes, sir. Yes, sir.
Go ahead, please.
Depending on the ISC, you would like to consider TK inhibitors. Then your classification comes up.
Sir, actually for TK inhibitors, no need of IHC markers, but they are considered only if the patient is rapidly progressive on the trial basis only, rapidly progressive patients with limited life expectancy.
So,
but IHC markers are useful to consider other forms of therapies which are under trial, sir.
Yeah,
like,
right.
Yeah.
So why don't you tell us a couple of histologies in which you would have ordered IHC after histopathology?
Yes, sir. Especially for anaplastic poorly differentiated variants.
What markers would you order?
Thyroglobulin and TTF, sir.
Okay. Any other marker which actually helps you guide systemic therapy? You mentioned something being on trial, but we do have the results of that trial, right? There is a specific mutation that has historically been associated with follicular neoplasms, a subtype of that mutation. Do you want to use one of those?
RAS. And another one is a PAX PPR gamma.
No, so that's for predicting the malignant potential of a thyroid nodule. The PAX PPR gamma will typically not help you guide systemic therapy. Is there any, again, I'll give you a little bit of a hint. In anaplastic carcinoma, let's say your histology was anaplastic and you wanted to give systemic therapy, which most anaplastic patients will need because it's very aggressive. Is there a particular mutation that you test for so that you can recommend certain TKIs that Dr. Siddhappa was alluding to? Have you heard of the BRAF V600E?
Yes, sir. BRAF V600.
Okay.
Yeah.
So if it's positive, what agents do you typically consider? Dabrafenib and trametinib.
Yes.
Can you see the chat box in front of you?
No, sir.
Okay. So Dr. Rai Jyoti Das has asked a question which I'll direct to you. What are the symptoms of dedifferentiation? Can you pick it up at the level of clinical examination only that you might be dealing with a dedifferentiated cancer? Kindly answer that question.
Yes, sir. Sudden rapid increase in size of the lesion.
Go ahead. More.
And new onset symptoms, rapidly progressing new onset symptoms.
Yeah. Aerodigestive tract symptoms. Dr. Panda pointed that out. It's important that you look at dysphonia, dysphagia, and dyspnea as being indicators not necessarily of dedifferentiation, but of aggressive variants of DTC, correct?
Yes, sir.
Okay. Dr. Jairaj also has a question. I'll read it out to you. When you mentioned intracranial, and the slide which is displayed, you mentioned intracranial, and I think Dr. Siddhappa also mentioned a little bit of that. Can you present as the soft tissue component associated with bone mets? She's specifically alluding to that point that it's not a parenchymal met. Because now that we know that it's follicular, it's probably a bony met that is probably extraaxial, right? So,
yes, sir.
Yeah, so you could probably specify a little bit more in your diagnosis slide, correct?
Yes, sir.
I think it was more of a comment from her side as opposed to a question, but I think that comment is well taken, that you should probably be more cognizant about writing even a more specific diagnosis because you're an exam going MCH. So people will expect that.
Yes, sir.
All right. Okay.
Dr. Krishna, your CT had shown that there was a large mediastinal component. So what are the cases where you will consider sternotomy while doing a thyroidectomy?
Yes, madam. Actually, we can classify these retrosternal goiters vertically into 3 categories. So the type 1 where it is extending reaching just above the great vessels, and type 2 it is going below the great vessels and up to the pericardium. Type 3 is below the pericardium. So type 1 usually we can get away with the cervical approach, madam. Type 2 we require manubrotomy, and type 3 we require sternotomy.
There is also a classification apart from the craniocaudal classification that you have mentioned, which is in
prevascular, retrovascular, and
yeah. Yes.
The
So,
A, B, C. Yeah.
Yeah. Can you tell us about that?
So prevascular, the type A, and type B is a retrovascular and pretracheal. Type C is a retrotracheal.
Type B can be further classified. B1 is a ipsilateral spread, and B2 is contralateral when it crosses over to the opposite side, and type C would be a isolated mediastinal goiter. So, in this case, would you be considering a sternotomy?
In this case, no need, madam. This is with extension we can get away, and during surgery, it will come into the neck.
Yeah, and moreover, since it's a reoperative field, patient has already been has undergone a hemithyroidectomy previously. So, what are the steps would you take to minimize the perioperative morbidities?
Especially in this case, you should be aware of contralateral recurrent laryngeal nerve and ipsilateral side. Try to preserve the parathyroids and contralateral.
Yes, on both sides you have to try and preserve the parathyroid. So if you're not able to preserve the parathyroid, then how do you manage the case? Suppose the parathyroid is devascularized, so what would you do next?
We can mince the parathyroid into small pieces and we can implant in the sternocleidomastoid muscle.
You have to first confirm by frozen section.
You have to send to frozen section to confirm. Yes, ma'am. Sorry.
Yes. Okay.
To get confused.
Of identifying imaging on table of a parathyroid gland, because other side you don't know the status of parathyroid gland, recurrent to the parathyroid gland. Considering that as other tool recently on table.
Sir, I actually am not clearly able to hear your voice.
He's asking if there is any imaging.
Any recent imaging where on table identification, on table identification.
Sir, on table, yes, sir. On table identification is there. Near infrared technology is there to identify the parathyroids. Now, many institutes are using that. But thing is, before implantation, 100% we should be sure that we should not implanting the central compartment node. So it is always better to go with frozen section before implanting. On table we can confirm with near infrared technologies. Near infrared.
What about iso green?
Yes, sir. In that they use isocyanine green also to check for the vascularity, and confirmation is by the near infrared technology. Irish something, the brand name.
So I'll add to that question. If you don't have ICG and the spy camera, is there any other localizing technique that you can use intraoperatively? See, normally it's all about location and color, but in a reoperative bed, as our co-moderator pointed out, it becomes a little difficult to follow standard landmarks. There are selective venous sampling that can be done. There is, and you can measure the washout PTH in those samples, and you can get some kind of idea. Frozen section, as you correctly mentioned, can be used. Okay. I'll again move to the focus of advanced thyroid cancer and I'll ask you a few questions about tracheal and vascular involvement. We'll talk about tracheal first.
Yes.
Based on the Shin classification and the grades of the Shin classification, can you tell us very briefly what you'll do in grade 1, grade 2, grade 3, and grade 4? What kind of surgery will you do in each of these?
Yes. In Shin 1, we can get away with the shave procedure because it's just abutting the perichondrium.
Correct.
So the Shin 2 also, you can partially shave off the thing because it is involving the cartilage, but it is not through and through. In Shin 3, it is coming into the submucosa. So definitely Shin 3 and require complete resection, ring resection in Shin 3 and Shin 4, where the submucosa are through the mucosa. So where you need mobilization of the trachea is needed. So Shin 1 shave procedure, Shin 2 we can go with window operation, and Shin 3 and Shin 4 usually require sleeve resection and mobilization of the trachea.
Yeah. In your
From the involvement of the segment.
In your summary,
Number of things.
In your summary, you were correct. I'm glad that you mentioned the window or the wedge operation. It is generally helpful in very short segments end to end. Tell me, if you're doing a tracheal resection and end-to-end anastomosis, what is roughly the length of trachea that you can mobilize? And again, we know that adult and male and female tracheas are separate, adult, pediatric, adolescent are separate, but just a brief idea.
So up to 5 centimeters we can mobilize.
With what technique can you mobilize?
With laryngeal release and
there are multiple types of laryngeal release operations. Which one are you talking about? Are you talking about suprahyoid release?
Yes, sir. Suprahyoid release.
Okay. Intralaryngeal release. Okay. How much can you mobilize with the with inferior mobilization?
With
inferior or mediastinal mobilization through the neck.
Mediastinal mobilization, we can go up to 8 plus 3 centimeters. Total 8 centimeters, I think.
So let's say you have a 6 centimeter tracheal defect. Your larynx was functional. One side of the current laryngeal nerve is preserved, and you still want to be able to bridge that defect and do a tracheo-tracheal anastomosis. What are the other techniques that you have to make sure that you're able to bridge this gap?
Yes, sir. Actually, for such a long segment defect, we cannot mobilize only by laryngeal release. So that thing require mediastinal mobilization. That is a Grillo procedure, sir.
Okay.
So where the left bronchus need to be separated from the bifurcation point, and it should be brought above the arch of aorta, and it should be re-anastomosed in the neck.
What if your tracheal involvement? So in the last scenario, we talked about a functional larynx. Let's say there is advanced laryngotracheal involvement. A lot of these patients might not be surgical candidates. Let's say you do select a patient who's good PS for surgery, and you're doing a laryngotracheal resection. Assume that the trachea at the inferior limit of the trachea is involved at the thoracic inlet, okay, but not beyond that. Do you have any option for that? What would you do in that case? How will you reconstruct the stoma? Because you already removed the larynx, so you want a stoma.
Yes. Sir, we can do stoma lower down.
Yeah, so a mediastinal stoma, right?
Yes, sir.
Okay. Is there a tracheal lengthening procedure that you've read about or you've experienced?
Tracheal lengthening procedure.
Yeah, or something like, I would say...
Yes, sir. Harvested rib cartilage they use.
Yeah, but again, you're talking about disease where you'll probably require adjuvant therapy. There are flaps and scaffolds with bony scaffolds that have been utilized in the past. The results are mixed, of course. I'll ask you about vascular management, okay?
Yes.
Let's say another patient with locally advanced cancer who has a 270-degree plane of contact with the common carotid artery, because that's the concern in terms of thyroid malignancy. We're talking about the primary eroding or encasing the common carotid artery.
Yes.
You think that this patient is curable, but the only thing that's stopping you is the 270-degree encasement of the carotid. How will you proceed? How will your workup change?
Sir, first I will check for the histology of the thyroid, sir.
Okay.
So if it is a differentiated malignancy, definitely it is resectable with a curative intent.
Okay.
So even if microscopic disease is left over the carotid sheath, I can treat it with radioactive iodine therapy.
That's fine. How will you work this patient up before taking the patient up for surgery?
Sir?
Will you do any specific investigations to see whether you'll be able to peel the tumor off the carotid?
Yes, sir. Actually, 270 degrees, what you have given is based on CT or MRI, sir, because
Let's assume CT. Let's assume CT. And I also would be interested in knowing why you asked that question. Please tell me.
Sir, in MRI, if it is a 270 degrees invasion is there, it is more significant, more difficult to peel it off rather than CT scan.
So again, anecdotal literature, single institutional retrospective. I know the study you're alluding to. It's kind of escaping my mind currently, but let's say 270-degree on cross-sectional radiology, and you want to do a workup to see that you're not stuck in a situation intraoperatively where you have to abandon the surgery. What investigations would you do to make sure that that you're in the right place or you're working the patient up correctly? Did you hear the question?
Yes, sir. Yes, sir.
Any occlusion?
Yeah. So Dr. Siddhartha is helping you out.
Balloon occlusion test.
Yeah, but prior to that, you would do, depending upon whether you want a CT or an MR, you do a CT.
Angiogram, sir. Actually, better to go for.
No, but it's important, and Dr. Siddhartha's point is very, very relevant, and we'll get to that. But
sir, angiogram to know whether the dominant circulation or not, and then we can go for total balloon occlusion test.
Now, what else do you want to know in an angiogram? You will be ordering how will you order this angiogram? What will you tell your radiologist? What do you need to order?
Sir, it is a I will ask for 4-vessel angiogram.
Okay, a 4-vessel angiogram. And what will you be looking for? You're looking at limitation of flow at the level of involvement. You're looking at dominant vascular supply, and you're also looking at, what else are you looking at? Anomalies in the circle of Willis, correct?
Yes.
You want to see an absent PCOM, which is very common, absent ACOM, or hypoplastic ACOM, which is fairly common. After this, we'll get to Dr. Siddhartha's question. And Dr. Siddhartha, did you want to ask him about the balloon test occlusion? Maybe he can try explaining to us how it is done, and then we can take it further. How is the balloon test occlusion done?
Yes, sir. In this, they pass the retrograde manner. They pass a balloon and occlude the internal carotid artery, and they will check for the tolerability of the symptoms, sir.
Yeah. Is there any adjunct to the balloon test occlusion that increases the sensitivity and specificity of the balloon test occlusion?
Xenon.
Okay, good. So xenon blood flow.
Xenon perfusion. Yeah, xenon perfusion. Yeah, right.
Now, let's say you have a situation where you have gross invasion of the carotid artery, but you have non-metastatic thyroid cancer, and it's a differentiated cancer. Okay. So you have now planned a thyroidectomy with a carotid resection and a neck dissection on the ipsilateral side. Okay.
Yes, sir.
Now, in this carotid resection, of course, you need a vascular surgeon with you. But can you give us some idea about when you decide to shunt the carotid, when you decide not to shunt the carotid, to make sure that the blood supply to the ipsilateral cerebral hemisphere does not suffer?
Usually, when it is a short segment, we shunt the carotid.
It depends on distal stump pressure, right, on the opposite side of the internal carotid, because in these patients, for the most part, you'll be doing a CCA to an ICA anastomosis, right? So yes, you shunt it if the distal stump pressure is below a set minimum. Most vascular surgeons would prefer 50. And you can check that once you place a Silverstein clamp on the distal ICA, so that you can check what's the cross vascularity. And of course, the little bit of things that will help you at that time are the fact that you know that you have a patent circle of Willis versus a hypoplastic circle of Willis and other factors.
Yes, I don't know, sir. Thank you.
Dr. Ravi will let us know about time, of course. But in the meantime, if anyone has any other questions, please go ahead, and then we can have concluding remarks after that.
Dr. Krishna, while during surgery, what all practical things you can do to avoid injuring esophagus or, nerve? Like any other technologies that you can use?
For now, we can use intraoperative nerve monitoring, madam. But it doesn't significantly change permanent nerve palsy. Only temporary nerve palsy can be reduced with intraoperative nerve monitoring. Especially, it is useful for revision cases like this.
So, did you use it in this patient? Just a normal question.
We don't have facility of intraoperative nerve monitoring, but we positively identified and preserved.
What's the kind of intraoperative nerve monitoring that are used for monitoring the recurrent laryngeal nerve?
Sir, actually, it is needed a continuous one.
Okay, so you should not say it's needed. You should.
Yeah, continuous type of intraoperative nerve monitoring is needed.
Yeah. So it's better. That being said, intermittent intraoperative nerve monitoring has been used for a long time now. It's now that CINM has shown to be slightly better.
Yes, sir.
how do you do intraoperative nerve monitoring? And I'm not talking about CIONM. I'm talking about IINM, intermittent.
So where the main electrodes and ground electrode will be there, sir. So you are asking for thyroid cases, sir?
Yes, of course.
Yeah. So here actually special type of ET tubes will come. So where it have a electrode. So whenever we are near the nerve, when we touch that electrode in the ET tube will be stimulated, sir. So when we are around the nerve, we can stimulate and see whether the cards are contracting or not. So more of prognostic use.
So there's something called, to add to what Dr. Kanika was saying, there's something called the high-risk thyroid surgery. And that, of course, includes reoperations. But the proponents of IONM would typically call any thyroid cancer surgery as high-risk surgery. That, of course, would probably be like taking it with a pinch of salt. We know that there cannot be a high-risk thyroid surgery for a low-risk thyroid cancer. But again, we're talking about advanced thyroid cancer. So I think IONM has a definite applicability. Dr. Kanika works in a center that has IONM and has used it for the last many years. So it's a useful adjunct in difficult cases and reoperative cases.
Yes.
We should ask Ravi if he wants to ask any questions. Ravi, please, if you're still there, go ahead.
Yes, sir. I'm good, sir. I think we can proceed as all the moderators want.
And if Dr. Shukla is here, I think we touched upon radioactive iodine and he had a great talk. But in case he wanted to comment on anything that Krishna Prasad would have mentioned, probably we can have him make a comment if he's still here.
I think he has left.
Okay. All right. So we have, for the sake of two questions that have just popped up, Krishna Prasad, I know you answered this already, but why don't you give us an elaborate explanation of why there is deep-seated eye pain?
Sir, actually, the involvement of the petrous apex and is cavernous sinus involvement and encasement. So actually, it is because of cavernous sinus involvement.
Or sympathetic nerves along the internal carotid artery.
Yes.
Yes.
Mainly it's due to sympathetic.
You mentioned something initially in your history which made me think of Horner syndrome. Please explain Horner syndrome, which is a fairly common entity after operating on large cervical mets from a thyroid cancer, and how do you mitigate the morbidity of Horner syndrome?
The Horner syndrome is the involvement of the sympathetic chain. So where we see the enophthalmos and mydriasis and loss of ciliospinal reflex.
So you said mydriasis. Did you want to check that?
It's meiosis, right? Not mydriasis.
So
sorry,
meiosis.
Meiosis, enophthalmos, ciliospinal reflex. Please tell us what the ciliospinal reflex is.
So pinching the skin of the neck, you will see the contraction of the pupil.
Okay. So in addition to the four things, Ratan has pointed out anhydrosis, that's the fifth cardinal symptom or sign.
Yes.
It's ptosis, meiosis, anhydrosis, enophthalmos, and loss of ciliospinal reflex. How would you mitigate it? Which of these actually needs mitigation or correction? The 5 manifestations of Horner syndrome.
So only ptosis need to be
surgically corrected. But in terms of anhydrosis and everything, you could of course have emollients and everything else, local therapies, topical applications and everything, right?
Yes.
So finally, how do you explain the loss of hearing in your patient? Was it incidental?
Sir, actually, I feel that petrous apex involvement is there. So that may be the reason for involvement of the. Yeah, yes, well, seventh nerve is not involved, sir. I know.
Yeah, those of us with an otolaryngology background would open up a lot of questions to that. Ratan again has an important point because you mentioned nasopharynx, right? So I think it's so important that that you realize that probably we are dealing with a conductive component. The fact that you noticed a nasopharyngeal bulge on the examination. Actually, I think you mentioned a parapharyngeal bulge on the oropharyngeal examination, or did you do a scope and did you say?
No, sir. On nasal endoscopy, we found that the nasopharynx bulge is there, smooth. Actually, we have done FNAC from that, sir. It came as a follicular deposit.
Oh, you did that FNAC from that. Okay. So let's make the discussion go that way then. If you're doing a guided nasopharyngeal FNA, again, first of all, guidance in that area is going to be difficult. But what all do you have to be careful of? It's unusual for you to do a nasopharyngeal FNA, right? Unless you are superficial and not doing anything.
Actually, we call pathologists and we only do guided FNS. A few times we have done for lesions. So we should be aware of any vascular vascular malformations, especially. We should be careful. Otherwise,
radiology to back it up. Yeah, absolutely. So, I think we are at that time which Ravi had pointed us. So, Ravi, if you wanted us to close the session, we could have all the moderators make 1 minute remarks and then just close the session.
Yeah, sure, sir. I think we are now at the point of our time of our conclusion. Before I thank my dear colleague Dr. Krishna Prasad for such a wonderful presentation, I would actually like to invite all the esteemed faculties for a concluding remark upon the presentation and any flaws or any concluding remark from your end. So you can start. Hello.
Should I go first? Okay. So I think Krishna, I think your confidence shone through. It was apparent that we were questioning an exam going PG in MCH. Most of the questions were answered to, I would say, my satisfaction. There were certain advanced points that I would encourage you to read up about, especially when you talk about structures which are not in contiguity of the thyroid. Remember that when you talk about thyroid, you'll also be asked questions about the neighboring structures, especially when the focus topic is advanced thyroid malignancy. Also, in addition to that, couple of basic points I pointed out at the beginning. Please make sure that your patient identifiers are not displayed either in your investigations. You had an FNA which showed an identifier. On 2 occasions during your PPT, the patient's name was mentioned. In today's age of documentation and HIPAA and everything, we just need to be extremely careful about that. Barring that, I think you understood most of the questions that were asked of a few by me and our co-moderators quite well. I think there were a couple of times when the answers to those questions could have been more succinct and more focused. But by and large, you did not digress from the core topic, which of course is commendable. And I think and I wish you all the best, and I think you'll fare well in your exam. Just be confident like you were today, and make sure that you answer to the point and answer concisely and comprehensively at the same time. Thank you.
thank you, sir.
Dr. Siddhappa, Dr. Kanika, Dr. Smriti.
Thank you very much for everyone. Submit Dr. Chopra is really good. Your moderation, and he presented well. And I didn't 130 therapy was very informative for PGs. It was good. Thank you very much. I got to urgent work. I have to leave. Thank you, everyone.
Yeah, very well presented, Dr. Krishna. It was really a good case presentation, and I think you answered most of the questions pretty well. So yeah, best of luck, and thank you, Ravi.
Thank you, ma'am. Dr. Smriti, anything from your end? Any point that you would like to add some concluding remark?
Yeah,
and one more
Dr.
suggestion from this one. I think every month if you keep one case like this, other than your PGs, it will be good for everyone. I feel so. Should be continued.
Sir, we are organizing this every 2 weekly on Thursdays, alternate Thursdays.
Oh, okay, good. Okay, fine.
If you know the next topic already, Ravi, you should announce at the right at the end of this talk.
Yes, actually, the next topic is already planned. It's carcinoma, unknown primary, next secondary, but all the speakers have not been finalized yet.
Oh, great. We look forward to that. And I think Dr. Smriti has to make a comment still.
Sure.
Yeah, all I wanted to say was the case selection was excellent. And Dr. Krishna, you have answered all the questions quite well. Thank you.
Thank you. Thank you, Dr. Krishna Prasad, for such a wonderful presentation. And I would like to thank all the faculties who have taken their time out from their busy schedule today for this wonderful academic event. Thank you, sir. Thank you so much. Thank you, ma'am. Thank you, Dr. Kanika, Dr. Smriti, Dr. Shamit, sir, Dr. Siddhappa. Thank you, everyone. Thank you so much.
All right.
Hope to see everyone in next session also. Thank you.
Okay.
Thank you, ma'am.